Assalamualaikum and good day. This is part 2 of the lecture Inflammatory Diseases of the Gastrointestinal Tract. My name is Dr. Mardiana Abdulaziz from the Department of Pathology, UITM. And in this part of the lecture, we will discuss chronic inflammatory bowel diseases covering the entities ulcerative colitis and Crohn's disease. At the end of this part of the lecture, you should be able to describe the etiology, pathogenesis, morphological features, and clinical manifestations and complications of ulcerative colitis and Crohn's disease, and skill-wise to identify the morphological features of ulcerative colitis and Crohn's disease. When we talk about chronic inflammatory bowel diseases, there are two entities that fall under this umbrella, which are Crohn's disease and ulcerative colitis. Some of their features overlap, while there are some features are distinct enough to allow distinction between these two entities. We will also highlight some salient features and pertinent differences between the two entities that allow their distinction from one another. So in general, inflammatory bowel diseases, or from here on will be abbreviated as IBD, tend to occur in younger age group with a second smaller peak after the 5th decade. There is a geographical variation in terms of its distribution, and in general, the incidence in Malaysia is actually not that high, especially if you compare it to the Northern Europe or the USA, for example, but the incidence is rising, especially for Crohn's disease, with an estimated prevalence of 9 per 100,000 cases, or approximately 2,000 to 3,000 cases in Malaysia. The precise causes or the etiology for inflammatory bowel diseases remain uncertain, but in terms of its pathogenesis, most investigators believe that it results from an alteration in host interactions with intestinal microbiota, a combination with intestinal epithelial dysfunction, and aberrant mucosal responses, as well as an altered composition of gut microbiota in susceptible individuals. So how do they propose this happen is that the composition of gut microbiome is altered in IBD. In addition, these patients also tend to have intestinal epithelial dysfunction or barrier defects, which allow transepithelial influx of microorganisms, which then activates an immune response, which unfortunately is dysregulated in these susceptible individuals. So this dysregulated immune response further increases the tight junction permeability and allows more transepithelial influx of microorganisms, and this leads to a self-amplifying cycle of inflammation. So it functions as an initiator of the inflammation as well as to maintain IBD in the long run. Okay, so have a look at that in terms of diagram-wise or picture-wise. So we can see here that the content within our gut lumen is rich in bacteria, and these bacterial population or microbiota can be modified by diet and disease. Okay, so in the setting of IBD, there is barrier defects. What happens is that in normal situation, you can see that there is kind of hardly any gaps or any pathways between the epithelial cells, but in the pathogenesis of IBD, there is tight junction barrier defects, which allows sort of small channels and small pathways leading to transepithelial influx of bacterial components, which are from the gut lumen, now coming into the mucosa. So in the insusceptible individuals, the susceptibility is conferred by several factors such as family history, some genetic abnormality, particularly that of the NOD2 gene. So what the genetic susceptibility does is that it leads to a deranged mucosal immune responses. So let's go back up one step, and you can see that there is transepithelial influx of bacterial components now into the mucosa, and these bacterial components now present themselves to the dendritic cell and this will initiate a sequence of inflammatory events, activation of inflammatory cells, and liberation of cytokines, as you can see, such as interleukins, tumor necrosis factor, etc. And these deranged mucosal immune responses actually lead to further increase in the tight junction barrier defect. So allowing more bacteria to influx into the mucosa and therefore amplifying and initiating and maintaining this cycle altogether. So this is the current hypothesis for the pathogenesis of inflammatory bowel diseases, and this applies to both Crohn's and ulcerative colitis between the two entities. So Crohn's, there are some features that would point towards Crohn's and there's some features that would point towards ulcerative colitis. So these are the list of features here. For example, the bowel regions involved, the distribution, whether or not the rectum is involved, bowel wall appearance, etc. So let's go through one by one. The bowel region, in terms of Crohn's, it can affect any part of the gastrointestinal tract, anywhere along the mouth to anus. So from your oral mucosa into the esophagus, into the stomach, small, large intestine. So all of these areas are potentially affected. But in contrast, for ulcerative colitis, the disease is limited to colon and rectum. Okay, so that's point number one. And the distribution is also different. Crohn's is typified by skip lesions, which means you have areas of inflammation and then you have normal areas and then you have inflamed areas again. So these are skip lesions. But in ulcerative colitis, the disease is often continuous and diffuse. The rectum is almost always involved in ulcerative colitis, but only sometimes in Crohn's. The bowel wall tends to be thick in Crohn's disease and thin in ulcerative colitis. Pseudopolyps is something that form as a result of residual islands of intact mucosa in a background of extensive ulceration, and these tend to be marked in ulcerative colitis and less so in Crohn's. The pattern of the ulceration is different. They tend to be deep and fissuring, or the terminology knife-like is sometimes applied to these ulcers in the case of Crohn's disease. But the ulcers in ulcerative colitis tend to be superficial and broad-based. The inflammation is transmural in Crohn's, but limited to the mucosa and submucosa in ulcerative colitis. And some of the features such as granulomas, fibrosis and stricture, fistulas and sinuses, fat and vitamin malabsorption, these can be seen in Crohn's, but rare to none in its occurrence in ulcerative colitis. Crohn's also has common recurrence after surgery, but not common for ulcerative colitis, and malignant potential applies to both entities. Okay, so just to illustrate those points a little bit better with images. Okay, so this is in terms of involvement. So Crohn's disease can affect anywhere, but ulcerative colitis just limited to colon and rectum. Skip lesions. Okay, so you can see inflamed areas are these red circled areas, and you have alternating inflamed, normal, with sort of no specific pattern whatsoever. But in ulcerative colitis, the inflammation is continuous and diffuse, and it will start from the rectum, because we say the rectum is pretty much always involved in ulcerative colitis. So the inflammation will start in the rectum and extend in a continuous manner proximally to wherever it wants to go. So it can involve up to, let's say, transverse colon, or it can go to ascending colon, can go to cecum. So if it involves the entire length of the rectum and the colon, then we call it pancolitis. And sometimes if that happens and if it's severe, you can have a little bit of involvement of the terminal ileum. But in general, the small intestines and the rest of the proximal GIT will not be involved. Okay? In terms of the extent of inflammation as well as the patterns of the ulcers, in Crohn's disease, the bowel wall tends to be thick, okay? But in ulcerative colitis, the bowel wall tends to be thin. The ulcer in Crohn's disease are thick, Okay, the ulcers in Crohn's disease are fissuring, so it's really narrow and sharp. Going in, as you can see, this one is almost the full thickness of the bowel wall. But in ulcerative colitis, the ulcers are superficial. They don't really go into the muscle layer, and they are broad based. Okay, so they're wide sort of in terms of its width. So this is a helpful differentiating feature between Crohn's and ulcerative colitis. And note how, because the ulcers are so broad based, so much of the surface mucosa and submucosa are lost. So whatever islands of residual mucosa and submucosa actually make up the pseudopolyp. So it's not a true polyp, but rather residual islands of intact mucosa, but it looks like it's protruding into the lumen, so hence why it's called pseudopolyp. Bear in mind this image because these patterns of inflammation and patterns of ulcers actually help explain why certain manifestations and complications occur in one entity and not the other. Okay. In terms of ulcers, so just to illustrate that again, diagram of what a histological appearance of these ulcers should look like. So deep fissuring ulcer in Crohn's disease is sort of a sharp V-shaped ulcer going deep into muscularis layer, or it could be even deeper than that, and a transmural inflammation which are illustrated by these purple and blue areas, goes all the way into the full thickness of the bowel wall, to the mucosa, submucosa, muscularis, as well as the subserosa. So this is transmural. And in contrast, the ulcer in ulcerative colitis is broad-based and superficial. See how it doesn't really go into muscle or deeper. And the inflammation is also superficial, involving the mucosa and the submucosa only. So again, it's highlighted by these kind of purple and blue dots. All right, so a little bit on Crohn's disease. Crohn's disease can affect, as I mentioned earlier, any area of the GIT, but the most common sites are the terminal ileum, ileocecal valve, and the cecum. 40% of the cases involve only the small intestine, and 30% involve both small and large intestines, and the remaining 30% involve only the large intestine. This is what Crohn's disease look like macroscopically. So on gross appearance, the most striking feature is the skip lesions. So the skip lesion means you have areas of inflammation alternating with normal uninvolved mucosa. So here you have inflamed mucosa, and here you have inflamed mucosa, but you have normal in between, separating the areas of inflammation. And down here is a segment illustrating the cecum, ileocecal valve, and the terminal ileum, which is a preferred site for Crohn's disease. Again, you can see that there is areas of inflammation and then of normal mucosa proximal and distal to it. Another feature that you can see, if you're viewing a segment of intestine involved by Crohn's disease, the mucosa can take an appearance of what we call cobblestoning, so cobblestone mucosa. It is called that because the appearance is quite similar to the cobblestones that you see sometimes in the park or even at the corridor near our ED in PPUITM. So you can see cobblestone, so it's a marked resemblance to that. And the cobblestoning of the mucosa occurs because of the deep fissuring ulcers that are present in these cases, which run through in between these islands of residual mucosa, so leading to the cobblestone appearance. Another complication is formation of fistula, which is an abnormal connection between either two loops of bowel or a loop of bowel with the lumen or cavity of another organ. And this occurs because you can have the deep penetrating ulcer which connects the two cavities together. Another feature that you can see is thickening of the bowel wall as illustrated here, and also what we call creeping fat. So the fat actually adheres to the serosal surface of the bowel, and this is because of the transmural inflammation involving the serosa in these cases. So the thickening of the bowel wall can lead to narrowed lumen and obstruction. Microscopically, the mucosa often shows inflammatory infiltrate. They can have abnormal architecture of the crypt. So rather than a nice rounded crypt, it's got branching and irregularity. But one of the most characteristic feature that you can see in Crohn's disease is the presence of a non-caseating granuloma. Okay, so there's a letter G there. And in this image here, this is a high magnification of the granuloma. So if you recall, the definition of granuloma is you have aggregates of epithelioid histiocytes, which are these cells with abundant eosinophilic cytoplasm, and mixed with Langhans-type giant cells. So these are your giant cells, and with a rim of lymphocytes as well. There is typically no necrosis associated with these granulomata. So this is histological findings of the other features that we mentioned earlier. So this is the deep fissuring ulcer microscopically. So ulcer is loss of the mucosa. So you have intact mucosa here, loss of the mucosa here where the ulcer is, and it is sharp and deep going into the muscle layer. And there is also inflammation present here. This image here on the top right shows you transmural inflammation. You have inflammatory infiltrate, which is very blue, going into muscle, and you have multiple lymphoid follicles in the subserosa as well. Okay, so this is transmural inflammation. And in terms of the architecture, there is some derangement with branching of the crypts and presence of a granuloma. So clinically, Crohn's disease can present with several features such as intermittent diarrhea, which may be bloody with fever, abdominal pain. Sometimes patients present with complications of the disease such as anemia, or you can have serum protein loss, hypoalbuminemia, uh, nutrient malabsorption, steatorrhea, weight loss. So these are presentation related to complications. Patients can also have extraintestinal manifestations, which include conditions such as uveitis, erythema nodosum, etc. Parts of the intestines which are involved in long-standing inflammation is also at risk of developing colorectal carcinoma. Let's compare that to ulcerative colitis. So macroscopically, ulcerative colitis, as we mentioned earlier, tends to involve the rectum moving proximally in a continuous manner, as you can see in the top right hand side here. And the mucosa often has a broad-based ulceration. You can see here as the areas of defect of mucosa, and the islands of residual mucosa here represents the pseudopolyps. Okay, so broad-based ulceration and pseudopolyps. The continuous manner of that inflammation is often characteristic in the sense that it leads to a sharp demarcation between the inflamed areas, which are really red and granular, all the other features of inflammation, and it often has a very sharp demarcation with the proximal normal appearing mucosa. The mucosa is atrophied, the wall is not thickened, the serosa tends to be normal, and there are no strictures. So these are the pertinent differences between UC and CD. Microscopically, so just to illustrate that, this is your broad-based ulceration, and the residual intact mucosa forms the pseudopolyp, and the inflammation is limited to the mucosa and submucosa. See how the muscularis propria and the submucosa are not involved by inflammation. Architectural distortion is also present in ulcerative colitis, so you can see crypt branching or irregularity. And another typical finding in an active inflammation is that you see neutrophils infiltrating the crypt epithelium as well as present in aggregates within the crypt, and these are called crypt abscesses. It tends to be a relapsing disorder with diarrhea, which may be bloody. Patients can have episodes of constipation with stringy mucus. They also complain of lower abdominal pain, urgency, tenesmus. They can have cramps, which are temporarily relieved by defecation, or they can have non-specific symptoms such as fever, fatigue, weight loss, present with complications, and also may have extra-intestinal manifestations. So let's discuss IBD complications. There are some complications which are shared between both Crohn's and ulcerative colitis, and some which are more commonly seen in one rather than the other. So some of the shared complications are listed in this table. The first one is anemia. Anemia can be of either iron deficiency type or anemia of chronic disease or macrocytic anemia. In general, iron deficiency anemia and anemia of chronic disease can be seen in both ulcerative colitis and Crohn's disease, and iron deficiency anemia is due to chronic blood loss as a result of mucosal ulceration, whereas anemia of chronic disease can occur due to effects of cytokines, which lead to ineffective hemopoiesis. Macrocytic anemia, on the other hand, is often a result of nutrient deficiency secondary to malabsorption. This can happen due to either in cases where the inflammation affect the absorption site, such as vitamin B12 absorption if there is disease in terminal ileum or the stomach, or it can also occur as a result of bowel resection. Okay, so sometimes a patient with Crohn's disease, severe Crohn's disease, they can undergo bowel resection, removing parts of the bowel which are involved by inflammation. So if you remove too much of that bowel, you can get short bowel syndrome. And if you remove parts which are involved in nutrient absorption, then you can get malabsorption of that specific nutrient. So you can get macrocytic anemia as a result of B12 deficiency, for example. Okay, another shared complication is malignancy, and this happens at chronically inflamed sites. They're preceded by a precancerous state called dysplasia, and the risk increases with increased frequency and severity of disease. And this is because we said that it could be a relapsing disorder. So the more frequent relapses someone has, then the risk increases with that. And the more severe the disease is, then the risk is also increased. The extent of disease, as in whether it only involves, say, in ulcerative colitis, if it only involves the rectum, then the risk is not as high as someone who might have involvement of the rectum all the way to cecum in pancolitis cases. And also duration of disease. In general, the risk of malignancy rises sharply if someone has been diagnosed with the condition for about 8 to 10 years or more. And then for extraintestinal manifestations, this is because the diseases in the GI mucosa triggers an immune response at extraintestinal sites due to some shared epitopes, causing manifestations at these sites away from the GI tract. Some of the complications are seen more commonly in one or the other. So in ulcerative colitis, the common complications include electrolyte disturbance, and this is because there is loss of electrolytes due to severe diarrhea. They can also have toxic dilatation or toxic megacolon, and this can happen because the ulceration can affect the muscle and impair viability and causes thinning. And also all the inflammation and inflammatory mediators damage the muscle and impairs neuromuscular function. Perforation can also occur because the bowel wall in ulcerative colitis tends to be thin, and this thinning of the wall confers a reduced strength to the bowel and therefore is more likely to perforate. The complications for Crohn's disease include fibrosis or stricture or obstruction, and this is because the transmural inflammation that occurs in this case will induce fibrosis of the wall, which leads to stricture and obstruction. Another complication is formation of adhesion. Okay, so adhesion is when one loop of bowel sticks to another, or formation of fistula or formation of sinus. And this is again as a result of transmural inflammation, which involves the serosa, and this will lead to formation of adhesions between the bowel loops. And we talked about the pattern of ulcer in Crohn's disease, which tends to be deep and fissuring, and this can lead to microperforations, so small areas of perforation in the bowel, which can connect to cavities or two lumen of loops of bowels together, and this leads to fistula formation. Okay, and the complications of malabsorption, which can be fat or vitamin deficiency, and this is because there might be inflammation involving the sites of absorption or short bowel syndrome, as we discussed earlier. So the deficiency can cause further complications such as anemia in vitamin B12 deficiency. You can have fat soluble vitamins deficiency secondary to fat malabsorption. So a quick recap on what we have discussed in this part of the lecture. We discussed the etiology of inflammatory bowel diseases, which remains uncertain. However, there is a theory underlying the pathogenesis of inflammatory bowel diseases, which involve an alteration in host interactions with the intestinal microbiota, intestinal epithelial dysfunction, and aberrant mucosal responses, and altered composition of gut microbiota in susceptible individuals. We discussed the differences between the morphological features between Crohn's disease and ulcerative colitis in terms of the parts of the GI tract involved, the distribution and patterns of inflammation, the characteristics of the ulcers, and also the microscopic features. And we also covered the clinical manifestations and potential complications of Crohn's disease and ulcerative colitis. So we have some shared complications, and we have some much more characteristic complications of each entity, and it relates to the inflammatory patterns and the disease distribution. So that marks the end of this part of the lecture. The references that I used were Robbins' Basic Pathology 10th edition and Underwood's Pathology 7th edition. Thank you very much.